I am Bernard Hirschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospital. You might call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies unequaled in the annals of medicine. Of course, this triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and their myriad manifestations. Hence, the idea of these videos. After a short introduction, they will feature a series of images illustrating one or several exemplary cases from my files. Before turning to case studies, let's start with a few minutes of theory. How to find an association between cancer and HIV? Well, we have to compare registries of HIV patients and of cancer, then calculate cancer incidence in the HIV-infected population and compare it to the incidence in the general population. These incidences have to be adjusted for confounders. In particular, age is important. Then express results by dividing the incidence in the HIV infected by the incidence in the general population. The result can be expressed as relative risk, as observed divided by expected, or most frequently by SIR, which are standard incidence ratios. Such calculations are shown in the following for the Swiss HIV cohort study. Kaposi's sarcoma and non-Hodgkin lymphoma are two of the best known AIDS-defining diseases. In these two graphs, the SIR for Kaposi's sarcoma and lymphoma are expressed as a function of the CD4 count at enrollment. These SIRs are very elevated for all categories of HIV-positive patients, and they rise further with declining CD4 counts. So for patients who have less than 100 CD4 cells, Kaposi's sarcoma is hundreds of times more frequent than in an HIV-negative control population. For lymphoma, the SIR reaches between 100 and 200. The influence of highly active antiretroviral therapy on SIRs is complex. If you look at Kaposi's sarcoma, it is hundreds of times more frequent in HIV positives who are not on HAART. The SIR in patients with HAART is still elevated, but much lower. Dividing the two, you arrive at a ratio of 10. For non-Hodgkin's lymphoma, it is similar. But for Hodgkin's disease, with an SIR of 17 without HAART, it's different. The SIR is even more elevated with HAART. Beyond KS and lymphoma, one has to consider confounders. What we mean by that is that patients who are HIV positive may be exposed to other factors than HIV which increase cancer incidence, particularly smoking, viral hepatitis, and the human papillomavirus. Here is a list of SIRs from the Swiss HIV cohort study. They go from more than 200 for Kaposi's sarcoma, 100 for non-Hodgkin's lymphoma, etc., to 3 for lung cancer. 3 may appear relatively modest, but you have to consider that lung cancer is so much more frequent than Kaposi sarcoma and non-Hodgkin's lymphoma. Patient A is a 32-year-old from West Africa who presented with right-sided abdominal pain and nausea. He was HIV infected, moderately immunosuppressed. He had abnormal liver enzymes, an astronomically elevated alpha-fetoprotein, and positive HBs antigen. These 3 CT scans show the catastrophic progression of a very aggressive hepatocarcinoma between April 2002 and February 2003. So this is an example of a cancer which is only indirectly associated with HIV. HIV positive persons are more frequently exposed to hepatitis B, which was probably the etiologic agent of hepatocarcinoma in this patient. On to lung cancer. There are 2 main risk factors for lung cancer. One is, of course, smoking, and the other one is age. In the left panel, you see that lung cancer in 60 to 69-year-olds is 1,000 times more frequent than in 20 to 29 years old. The central panel compares smoking prevalence in 3 populations. Red in those HIV positives who acquired HIV through IV drug use, more than 75%. Other HIV positive persons, about 45%, and the general population in Switzerland, about 30%. These data are from the early 2000s. And finally, consider that the median age of those patients who probably became positive for HIV through IV drug use was less than 30 in 1988 and more than 50 in 2022 in the HIV Swiss cohort study. So the conjunction of all these data means that lung cancer is expected to be frequent in HIV positives. Patient B is a typical example. This was a 45-year-old ex-IV drug user, smoker, HIV positive, with 277 CD4 cells, presenting with seizures. The chest X-ray showed a large mass in the right upper lobe, and the CT scan showed brain metastases. The diagnosis was confirmed by bronchoscopy. But the diagnosis of lung cancer is not always so straightforward, as shown in the next 2 examples. Patient C was a 58-year-old ex-drug addict, HIV positive, and admitted for confusion, fever, and weight loss in May 2001. I quote the report of the CT scan of May 19, 2001. Intracerebral polycyclic lesions with a differential diagnosis of toxoplasmosis, lymphoma, or abscess. The probable diagnosis was cerebral toxoplasmosis, and a therapeutic trial of sulfadiazine and pyrimethamine was started. There were psychiatric problems with agitation and aggression of personnel. He was transferred to the psychiatric ward, but almost immediately sent back because of cough and fever. These are two CT scans from May 19th and June 1st, 2001. Consider that in the interval, the patient was treated against presumptive toxoplasmosis. One can understand, therefore, that the radiology report from June 1st reads, compared to the preceding scan, the lesions previously seen have increased in size. The most likely diagnosis is lymphoma. However, the chest X-ray suggested yet another diagnosis. Pneumocystosis? During attempted bronchoalveolar lavage, the pneumologist saw that the posterior and apical segments of the right superior lobe were obstructed. Cytology and biopsy showed an undifferentiated carcinoma, and no pneumocystis were seen. In retrospect, a mass was already present in the right upper lobe on May 19, 2001. The patient died on June 6, 2001 from a large cell undifferentiated pulmonary carcinoma with brain metastases. Case D is the mirror image of case C. A 53-year-old smoker and heavy drinker who loses 10 kilograms complains of headaches and dysphagia. The suspicion of a digestive or lung cancer was not confirmed, however. The MRI brain scan showed multiple lesions interpreted as probable metastases of unknown primary, leading to a brain biopsy, which surprisingly revealed a toxoplasma abscess. You see it here on the left with a red line indicating its approximate margin. On the right, a magnified insert showing toxoplasma tachyzoids indicating active replication. Only then was an HIV test done, which was indeed positive with 56 CD4 cells. This was 2002. The patient could be reassured, this is only AIDS, don't worry about lung cancer. And indeed, he did extremely well on pyrimethamine, sulfadiazine, plus highly active antiretroviral therapy. This video is part of a series on opportunistic diseases in HIV/AIDS. I'd be grateful for any feedback that you might have. If you are interested, please subscribe.